patient is hyperthermic, or if the patient has tremor, and the patient is on methadone along with the medications which we have described, please think of whether it is due to serotonin syndrome. So as I told, this is a very rare entity. So it is, I have not seen any patients with the serotonin syndrome, or I haven't heard of serotonin syndrome uh, my from my colleagues also. So it should be very, very rare. So those were the three effects which was advantages in pain relief. But this is an effect which is disadvantage. This is the action on human either agogo related gene, and when methadone blocks a human either agogo related gene, it increases the QT interval, which leads to torsade points, and it can cause sudden death. So this is the most feared side effect of methadone, and many of the doctors are not willing to start patient on methadone because of this problem, because of this increased QT interval and producing torsade points, which can lead on to death. Okay, so there are many risk factors for methadone. So you can see the patients with the electrolyte abnormalities, calcium, potassium, and magnesium. Those are the three electrolytes, or decreased level of those electrolytes can lead to increased QT interval and torsade points. And patients who are elderly, female gender, structural heart disease, patients with heart failure, malignancy, peptic ulcer disease. And when the dose of methadone is more, that is more than 45 milligram of methadone per day, it can increase the QT interval. So as long as you are uh, starting the patient on lower doses of methadone, probably you are safe in terms of QT interval. And here you can see a study by Dr. Suresh Reddy et al. From MD Anderson Cancer Center, and they have started methadone in 100 patients, and they monitored these patients with the ECG for understanding if methadone produces QT interval, which leads to fatal arrhythmias and death. And they took ECG when the patient was started on methadone, and then 2 weeks, 4 weeks, and 8 week interval. And their finding was there were no patients who had torsade points or fatal ventricular fibrillation, um, even though there were some patients had a prolonged QT interval. But you can see the median dose of methadone used here is 23 milligram with a range of 3 to 90 milligram per day. So probably this study says us that when the dose of methadone is less, the chance of clinically significant QT interval prolongation, which lead on to torsade points and ventricular fibrillation, are very, very less. Okay, so if you are using a smaller dose, less than 40 milligram per day, you are safe in terms of QT interval. And there are many medications which can produce increased QT interval other than methadone. Okay, so these are medications which we use commonly in palliative care. You can see the macrolide antibiotics, azithromycin, clarithromycin, erythromycin, and fluoroquinolone, ciprofloxacin, levofloxacin, azole antifungals, fluconazole, then SSRIs, citalopram, escitalopram, antipsychotics like haloperidol, and 5-HT3 antagonists like ondansetron. So all these are medications which we use commonly in palliative care. So when you use or when you start a patient on methadone, please see whether any of these medications are already prescribed for this patient. And if it is there, you have to change or modify the medication. Okay, so this level of risk is further divided into definitive risk, possible risk, and conditional risk. I'm not going to read all the medications. But the most important medications are those which I have already told you. So let's move on to pharmacokinetics of methadone. So what are the routes through which you can administer morphine? What are the routes through which we can give morphine?
Sir, intravenous,
Yeah,
subcutaneous, oral.
yes, yes. Any other routes? Intrathecal by Dr. Priyanka. Anybody? Epidural? Yes. Nasal spray. Nasal spray. Uh, I think nasal spray is not available. Morphine nasal spray is not available. Patch is also not available. Morphine patch is not available. Yeah, one more route, which is that. Yes, parectal. Yeah, parectal. Yeah. Can you give morphine sublingually? Anybody? Can you give morphine sublingually? Sublingual or transmucosal absorption is not proper. Yes, that's correct. So morphine cannot be given or should not be given sublingually because as Dr. Jyoti told, um, its absorption is very much variable. Uh, and you have to keep it under the tongue for a long time. We don't know how many hours. So if some patients tells you that after sublingual administration, I have pain relief, that means they have swallowed it. That's why they have pain relief. So morphine is not advisable to give sublingually. But in case of methadone, it can be given sublingually. Okay. So like morphine, it can also be administered parectally. So oral, sublingual, and parectal. And mm, parenteral preparations or injections are available uh, outside India, but injections are not available in India. We have only tablets and syrup. Okay. So after absorption, it undergoes metabolism extensively in liver, and then it is distributed throughout the body. So what happens once methadone is administered? So you can see after administration, uh, methadone can be seen in the blood for 2 to 4 hours. I'm talking about a patient who is started on methadone for the first time. So for the first 2 to 4 hours, methadone will be available in the blood, and during that time, the patient can have some pain relief. But immediately after this 2 to 4 hours, all the methadone will be disappearing into the tissue binding sites. Okay, so methadone will go to tissue binding sites and will start binding to the tissues till it gets saturated. Okay, so this is how it happens. You can see all the tissue binding sites are saturated, and once it is saturated, then the methadone will be slowly liberated into the systemic circulation, and only a very small fraction of methadone will be liberated into the systemic circulation once the tissue binding sites are saturated. And for this phenomenon to occur, or uh, it will take about 5 to 7 days for the tissue binding sites to get saturated. So in case of methadone, you have to wait for 5 to 7 days to get a good pain relief. So that's what you have to understand. But in case of morphine, how long will it take to get a sustained pain relief? Methadone will take 5 to 7 days for sustained pain relief. Whereas morphine will take how long?
Sir, we have a
24 to
maximum.
40 hours. Immediate. Morphine will give immediate pain relief, but how long will it take uh, to have a sustained effect? Yeah, it is 24 hours. Okay. So you can increase the dose of morphine every 24 hours. Whereas in case of methadone, you have to wait at least 5 to 7 days before you increase the dose of methadone. So this is very important. So from this, you can guess that methadone will not be a suitable medication for a patient who has acute severe pain. And this is important. We told that uh, methadone is metabolized in liver, and there are various cytochrome enzymes involved in the metabolism of methadone. You can see cytochrome 2b6, 3a4, 2d6, 2c19, and there are many other cytochromes. And we also know that many medications are metabolized in liver through cytochrome enzymes. So obviously there will be interactions with methadone for many of the medications because methadone metabolism is done by various cytochrome enzymes. So when you start a patient on methadone, you have to see whether there are any strong inhibitors or strong inducers. Okay, so what are those medications? So here there are a few medications which are cytochrome P inhibitors. So the most common medications, azole antifungals. So in palliative care, many patients will be getting fluconazole, ketoconazole, itaconazole, etc. So you have to see any of those medications are there. Macrolide antibiotics, azithromycin, clarithromycin, erythromycin, etc. So those are two medications which is commonly used in palliative care. So before you start patient on methadone, please see whether the patient is already prescribed on these medications because these are going to inhibit the metabolism of methadone so that there will be increased methadone available in the blood and that can lead on to toxicity. So it is advisable to reduce the dose of methadone by 25% uh, if there are any strong cytochrome P inhibitors. But if you are giving cytochrome P inducers along with methadone, like phenytoin, phenobarbital, oxcarbazepine, carbamazepine, etc., the metabolism of methadone will be fast and it will lead to reduced level of methadone in the blood. So the patient, if the patient is on or patient was taking methadone for a long time, there is a chance that the methadone levels in the blood might be reduced and what can cause this or what what will be the effect of this reduced methadone levels in the blood? What will be the effect? Inadequate analgesia, yeah, that's correct. Anything else? More doses needed, yes. Inadequate analgesia, so more doses needed, yes, that's correct. Anything else? The patient was taking methadone for a long time. Suddenly there was a reduction in the blood concentration of methadone. Definitely it can cause more pain. What else it can cause? Yes, it's withdrawal. Okay, because the blood level of methadone has reduced and it can sometimes lead on to withdrawal. So if you are starting a patient on these medications and patient is on methadone, please watch the patient for any withdrawal symptoms. Okay. So there are a lot of medication which can either increase the methadone level or reduce the methadone levels. So see here, um, on the left hand side, there is amitriptyline, citalopram, escitalopram, fluoxetine, sertraline, lansoprazole, omeprazole, pantoprazole, cotrimoxazole, ciprofloxacin, clarithromycin, erythromycin, fluconazole, itraconazole, ketoconazole, etc. So all those medications which we usually use in palliative care, whereas the medication which can reduce the methadone levels are mainly uh, you can see ritonavir, efavirenz, rifampicin, phenytoin, carbamazepine, phenobarbital. Okay, so there are many medications. The stronger one we have already um, seen in the previous slide. So, which are the patients for whom we can start on methadone? So, literature says methadone can be used as an adjuvant. So, can anybody tell me what is an adjuvant? Anybody?
Sir, it is a drug used with another drug and which potentiates the first drug that
Okay,
has a
yeah,
added mutation.
yes, that's correct, Jasmine. Anybody else has any other definition?
Sir, we have an answer in chat box by Dr. Jyoti. Is beneficially quick as well as co-analgesic by Dr. Madhumati. Sorry.
Okay, okay. Any other definitions?
Sir, an adjuvant is basically a drug which is not the primary drug of choice for that particular state. For example, we are giving some drug which is the primary analgesic, and to supplement it, we are giving some other drug which is just increasing in a supplementary way, and it is not as such a single mode of treatment.
Okay, so what Priyanka tried to tell us is that adjuvants are medications whose primary action is not pain relief. So adjuvants are medications whose primary action is not pain relief, but is helpful in some painful condition. So please take tricyclic antidepressants. What is the primary mechanism of action? It is the antidepressant action, but it is helpful to treat neuropathic pain, and that's why it becomes adjuvant. Okay, so what is the primary mechanism of action of methadone? What is the primary action? Is it other than analgesia or is it an analgesic? Methadone is primarily an analgesic, isn't it? So why are they calling or it is given as an indication that methadone can be used as an adjuvant. So suppose a patient who is on 10 milligram or 20 milligram of morphine every 4 hours day, and the patient is having very good pain relief except at night. So in that patient, if you use a small amount of methadone, maybe a 1 milligram or 2.5 milligram of methadone, that patient will get very good pain relief. So if methadone is used along with other opioids in smaller doses, the literature call it as an adjuvant. Okay. So even though it is methadone is not really an adjuvant, it is an analgesic. So we cannot call it as an adjuvant, but still this adjuvant, the word adjuvant has been used in case of methadone if it is methadone is used in small amounts with other opioids. I hope it is clear. And another indication is being refractory to other opioids. So we know that there are some patients for whom we have started on morphine or fentanyl. Still the patient has no pain relief. So in such patients, we can start patient on methadone. Complex neuropathic pain, especially patients with head and neck malignancies or patients with the pelvic malignancies, where there is high chance of nerve infiltration. Then patients with significant renal impairment. So we know that in case of significant renal failure, morphine and its metabolites can accumulate and it can lead on to toxicities. But methadone is supposed to be a safer alternative in such condition, because most of the metabolites of methadone is removed through feces and a small amount through urine. And if the patient has high opioid tolerance, which we have already seen patients on thousands of milligrams of morphine, uh, and when they added a small amount of methadone, all the patients got good pain relief. And sometimes the patients can have opioid-induced hyperalgesia, which is a very rare phenomena. I have not seen much cases of opioid-induced hyperalgesia. I have seen only one or two patients. So patients who was on small amount of opioid and later uh, they were they were given more dose of the same opioid because of increased pain. So there were these patients will then respond to increased doses of morphine. But after a certain duration, sometimes even if you increase the dose of the opioid, rather than pain relief, these patients will have more pain and hyperalgesia. So this is a very rare phenomena. In such patients also, methadone is indicated. Then patients with poorly controlled opioid adverse effects. Suppose the patient who was started on morphine have nausea and vomiting. We know that nausea and vomiting is self-limiting within 3 to 5 days, and you will give him haloperidol, metoclopramide, or even ondansetron. But you have tried various methods, and patient doesn't have proper relief for nausea and vomiting after 1 week. Then in such patients, maybe methadone may be an option. And if the patient is allergic to other opioids, then you can start him on methadone. So please see, these are the indications for which you can start patient on methadone. So there are some inappropriate candidates for which for whom we should not start methadone. So family history of sudden unexplained death. So uh, if there is sudden unexplained death, it might be due to familial QT prolongation syndrome. So you will get the history of sudden unexplained death in the family. Then congenital QT syndrome. If the patient has congenital QT syndrome, don't start patient on methadone. If the corrected QT interval more than 500 milliseconds, then if the patient has poor cognitive function, uh, so that patient will not be able to communicate to us properly. So in that condition, don't start methadone. And it is not like morphine. Uh, Even if you sometimes some patients may take more than the dose which we have prescribed. Suppose you have written 5 milligram of morphine and patient took 10 milligram of morphine, but that may not cause much problem. Uh, but uh, suppose you have written uh, 1 milligram of or 2.5 milligram of methadone and patient took 5 milligram of methadone instead. The effect will be seen after only 1 week. But in case of morphine, you will see the effect in 24 hours. So by the end of a week, the patient suddenly will have all the opioid toxicities, and it will be difficult to reverse also. So it is not advisable to give methadone for a patient who doesn't have a proper caregiver. And in case of acute pain, methadone is not a good choice, because we know that you have to wait for 5 to 7 days for sustained pain relief. So in case of acute pain, please don't start patient on methadone. So methadone has the QT interval prolongation, and it can lead to toxide points. So how should we monitor the patient? So the monitoring the patient should be aligned with the goals of care. That means if the patient is, suppose the patient is having a chronic disease, and he's only for comfort care. In such patients, the goals of care is comfort care. So in such patients, we need not do much investigation. But if the patient is undergoing any curative or any other interventions which can modify the disease, and in such patients, we have to do investigations. So the basic investigations need to be done are ECG and potassium, magnesium, and calcium, because hypocalcemia, hypomagnesemia, and hypokalemia, which can lead on to increased QT interval and toxide points. So this is the basic investigation. And how frequently should you do ECG? So when you start the patient on methadone, then when you reach the dose of 30 to 40 milligram, and then when a dose reaches to 100 milligram. So this is how you will monitor the patient. So this is the preparation available in India. So you can see the tablets, which is 5 milligram tablet, and syrup, in which 1 ml contains 5 milligram of methadone. So this is produced only by one pharmaceuticals, that is Rusan in India, and its trade name is Harmeth. So now we will move on to conversion. How can we convert a patient from morphine to methadone, or from any other opioids to methadone? So what you have to understand is, whatever be the patient, whatever be the opioid the patient is on. Suppose the patient is on fentanyl or tramadol, you have to convert it into morphine, and then from morphine to methadone. Okay. So this is the conversion method which we are using. If you look at the literature, there will be many conversion methods available, but all those are very much complicated. This is the most recent one, and this is by hospice and palliative care physicians, which was published in Journal of Pain and Symptom Management in 2019. And you can see if the patient is taking less than 60 milligram of oral morphine equivalent per day, the dose which you can start is 2 milligram to 7.5 milligram per day. Okay. And if the patient is taking morphine equivalent 60 to 199 milligram, and if the patient is less than 65 years old, the conversion ratio is 10:1. That is 10 milligram of oral morphine is equal to 1 milligram of methadone. And if the patient is taking more than 200 milligram of methadone, or if the patient is more than 65 years old, conversion ratio is 20:1. Okay. So less than 60 milligram, 2 to 7.5 milligram per day. 60 to 199 milligram, 10:1. More than 200 milligram, the ratio is 20:1. And how will you increase the dose of methadone? So as I told you, you have to wait for 5 to 7 days before you increase the dose of methadone. And if the patient is taking less than 30 milligram of methadone per day, you can increase 5 milligram per day of methadone. And then you have to wait for another 5 to 7 days for further increase. If the patient is taking more than 30 milligram per day, you can increase 10 milligram per day and wait for another 5 to 7 days before further increase. And we already told that you have to wait for 5 to 7 days before you increase the dose of methadone. But in case if the patient is elderly and if the patient has liver derangement, it is better to wait for 10 to 14 days because methadone will take such long time to get the blood level stabilized. So in case of elderly or patients with liver impairment, be patient and take more than usual days to have sustained pain relief. So we will move on to some patients. So this is a 37-year-old man who was diagnosed with carcinoma of the buccal mucosa in 2018, and then he was diagnosed with another primary, that is papillary carcinoma of the thyroid, and he underwent surgery and radiation. But in 2019, he had level 2 nodal recurrence and underwent surgery. But later, he had severe pain, and then oncologist told it is because of the recurrence, and there is no oncological interventions possible at this time. And this patient presented with severe pain, and he described it as starting inside the left ear, going to the lateral side of forehead, then to submental region, and he described it as pricking pain and scores 10 by 10. So you can see the pain distribution is in the area of mandibular nerve, the pink area. And this patient was seen by another hospital, and because of this neuropathic pain, they tried mandibular nerve block, but the patient didn't had any pain relief. You can see the patient how he is sitting, his posture. And then because of the interventional pain management, the patient didn't had pain relief. He was started on injection morphine, but with that patient had toxicities, and then they started him on tab morphine like this: 10 milligram, 15 milligram, 10 and 30 milligram with 10 milligram SOS. Even with this dosage, the patient had toxicity. So they also added various adjuvants like tricyclic antidepressants and anticonvulsants because of this neuropathic pain. But a patient didn't have pain relief. So this was the medication the patient was taking when he came to us: tab morphine 10, 15, 10, 30, tab pantoprazole, ciprofloxacin, escitalopram, serratiopeptidase, diclofenac patch once every day, tab paracetamol 650 milligram, 1 SOS. So, uh, so is this a patient for methadone? Is this a suitable patient for methadone? Yes. Okay. If we can start patient on methadone, what are the indications to start methadone in this patient? What are the indications to start methadone in this patient? Yes, morphine toxicity. Yes, that's good. To reduce tolerance. Okay. Non-responsive to morphine. Yeah. Non-responsive. Yeah. Refractory to morphine. Yeah. What else? One more. Morphine toxicity, refractory to other opioids. Yes, neuropathic, complex neuropathic pain. Yes. So those are the three indications by which you can start patient on methadone. patient on methadone. Yes. So before starting methadone, what all should you do? What all should you do? ECG, ECG and electrolyte. Yes. Anything else other than ECG and electrolytes? Yes, you need to review the drugs. Family history of what? Yes, family history of sudden unexplained death. Yeah, that's very good. So you have to get, you have to ask the patient whether there is any history of sudden unexplained death in the family. Okay. What else you have to ask? Reliable caregiver, isn't it? So these are the uh, two prerequisites for starting methadone and ECG and electrolytes. What is the goals of care in this patient? A patient who has two primaries and who underwent surgery, radiotherapy, and chemotherapy, and now the patient has recurrence. So, what is the goals of care in this patient? Yeah, it's comfort care. So, actually, we need not investigate this patient. But if you are going to start methadone for the first time, it is better to do these investigations. So you decided to start the patient on methadone. Okay. So these are the medication the patient is on. Do you have any concerns with these medications when you are going to prescribe methadone? Yes, ciprofloxacin and citalopram concurrent use should be kept in mind. Yes, very good. Ciprofloxacin and acetalopram, they all can cause increased QT interval. And even pantoprazole can also cause increased QT interval. Okay. But out of this, ciprofloxacin and acetalopram are the medication which has definite risk. So now you have to calculate the dose of methadone. So what would be the dose of methadone for this patient? Yeah, 65 milligram of morphine. So 6 milligram. Yeah, yeah. Okay. So oral morphine, this patient is taking total 65 milligram, isn't it? And the conversion ratio, what is the conversion ratio? It is 1 by 10, isn't it? So patient is age is 39 and the oral morphine equivalent is between 60 to 199. So the conversion factor is 1 by 10. So 65 divided by 10, that is 6.5 milligram of methadone per day. So if you have only tablet, you need to give 2.5 milligram BD, or if you have syrup, you can give 3 milligram BD or even 2 milligram TID, because the duration of action of methadone is 8 to 12 hours, whereas the duration of action of morphine is 4 hours. Uh, so, are you happy with this? So you just prescribed methadone for this patient. Do you need to give anything along with methadone. How many days will it take for pain relief? Yes, 5 to 7 days. So till that time, what are you going to do for this patient? For the 5 to 7 days, what are we going to do? Continue morphine. Yes. Okay. And we have to continue morphine, but it is not on a regular basis. It will be on a SOS basis. Okay. So you can see we are giving tab morphine 10 milligram Q4H on SOS basis. So if you write a normal prescription of morphine, it will be written as tab morphine 10 milligram Q4H and SOS. But here it is Q4H SOS. So on a 4-hourly basis, if needed, you give morphine. That's what it means. So suppose at 6 a.m. you have given methadone, and at 6 a.m. you will ask the patient, do you have pain? So if the patient says yes, you will give morphine. And 10 a.m. patient says, no, I don't have pain. You will not give morphine. 2 p.m. patient says, no, I don't have pain. You will not give morphine. At 6 p.m. patient says, I have pain. You will give morphine. So that's what Q4H SOS means. Okay. So for this patient, methadone, morphine, and all of you told ciprofloxacin and escitalopram. So ciprofloxacin should not be given. So instead of that, give antibiotics which doesn't have more interaction with methadone. So you can give amoxicillin. And actually, this patient was the escitalopram was stopped in this patient, and we have to give bisoprolol because methadone is also an opioid and it is going to produce constipation. Okay, now we'll move on to second patient, 39-year-old woman with carcinoma of the pancreas, stage 4 with liver metastasis, and she received 5 cycles of chemotherapy, and the oncologist stopped chemotherapy because she had a progressive disease. It was not responding. Sure. So this is the type of pain she was describing, which starts on the left lateral chest and going on to the back. She described it as pricking, stabbing type of pain, which scores 10 by 10. And she also had myoclonus. These are the medications she was taking: tab morphine 20 milligram Q6 hourly, injection tramadol 100 milligram IV TID, injection paracetamol 1 gram 6 hourly IV, gabapentin 100 milligram TID, amitriptyline 25 milligram HS, bisoprolol 5 milligram 2HS. So this patient says even with this medication, her pain score come down to 8 by 10 from 10 by 10. So that's all what she has with morphine and tramadol. So is this patient a suitable candidate for methadone? This is anybody? You can unmute and speak. Yes.
So there is an indication, as seems like, for methadone, but there is a confusion regarding myoclonus because methadone also causes some neuromuscular side effects like tremors, etc. So I'm a little confused about that. Otherwise, because of opioid, it seems like opioid resistance. So yes, there is an indication in that way also.
Okay. Any other indications? What are the other indications? Yeah, Dr. Nandini is talking about the prescription. Yes, you are right, because um, here opioids for mild to moderate pain is given along with opioids for moderate to severe pain. So morphine and tramadol should not be combined. Um, you need to give only one opioid. So mm, but this patient was when she came to us, she was on this prescription. Okay. So opioid toxicities. So myoclonus and other toxicities of morphine, then neuropathic pain and pain refractory to other opioids. So these are the indications to start a patient on methadone. So do we need any investigation? Actually not, because the goals of care in this patient is only comfort care. Okay. And what is the dose of methadone this patient is needed? So please calculate and tell me what would be the dose required for this patient. Eight mg. 8 mg, yeah, Dr. Madhuvida and Dr. Jyoti, Dr. Purnima. 8 mg. Okay, anybody has 10 mg? Dr. Priyanka says 10 mg. So let us ask Dr. Priyanka, why 10 mg?
So because from morphine we get 80 mg 6 hourly,
Yeah.
and then tramadol is also an opioid, so we need to convert it into morphine first, oral morphine equivalent, as you said. So tramadol is 1/10 of morphine.
Yeah. So this is what you have to be careful here. You have to convert all the opioids into oral morphine equivalent. So here there is already morphine, but you have to convert tramadol to morphine. Okay. So here it goes. She is taking 20 milligrams 6 hourly. So she is getting 80 milligram of morphine. Now you have to convert tramadol to morphine. So the potency of tramadol is 1/10 of that of morphine. So 300 milligram of tramadol divided by 10, which comes to 30 milligram. So total she is taking 110 milligram of oral morphine equivalent. And her age is 39, and her oral morphine equivalent is between 60 to 199 milligram. So the conversion ratio is 10:1. So she should get 11 milligram of oral methadone. So start with tab methadone 5 milligram BD. Okay. Do you have any concerns with these medications? Any of these medications? Amitriptyline, yes. Dr. Jasmine and Dr. Manjiri says they have concerns with amitriptyline. Yeah, because amitriptyline along with morphine can increase the methadone levels. So there is a problem, but and because the dose of amitriptyline is very small, either you can stop it or you can continue. But it is good to understand that amitriptyline has some interaction with methadone. So actually, we did not stop amitriptyline for this patient. We continued with 5 milligram methadone morphine was given on 20 milligram on a 4-hourly SOS basis, continued gabapentin and amitriptyline. Actually, this patient, this young lady was very sad because she was unable to take care of her children as well as her husband. And she was confined to a room. But after starting methadone, this patient became very active and she could go out and attend many social functions. She was very, very happy for the 2 months she lived. And that is the wonder um, methadone can give to some of the suitable patients. So this is another patient, a 40-year-old man with advanced malignancy of the lung with spine metastasis. And he had a T12 compression fracture for which he received palliative radiotherapy. But after some time, the patient was complaining of burning pain on both lower limbs, which is continuous and scores 9/10. Patient is on this medication, tab morphine 40 milligram Q4H, amitriptyline 25 milligram 3HS, pregabalin 75 milligram 202. There is no pain relief. Suppose you want to convert this patient to methadone. What would be the dosage? Twelve milligram. Jyoti says 12 milligram BD. Jasmine 12 milligram. Okay. Yeah. Let's see. So this patient is taking a total of 240 milligram. So conversion factor is 20:1 because patient is taking more than 200 milligram of oral morphine equivalent. So 240 divided by 20, that is 12 milligram of methadone. So it should be 5 milligram BD or syrup methadone 4 milligram TID. You have to continue morphine on a 4-hourly SOS basis. And amitriptyline was reduced to 50 milligram, reduce it to 50 milligram, and then in subsequent visits, taper and stop. Continue the pregabalin. So that is the practical application of the knowledge that we have obtained through this session. And these are the certain resources available in net. If you want to know more about cytochrome P interaction as well as QT prolongation. So from this session, what I want to convey is that methadone is a very useful opioid in selected group of patients. It can actually cause wonders to the patients. Many of the professionals may not start the patient on methadone because of the fear of QT interval prolongation, which can lead on to torsade points. But it is important to note that these QT interval prolongation and torsade points, these studies were mainly conducted on patients who are on opioid substitution therapy. And please understand that these patients will be on hundreds of milligrams of methadone. So we know that when the dose of methadone is more, the chance of QT interval prolongation is more and torsade points are more. So the doses which we are going to use is mainly less than 40 to 50 milligram of methadone. So in that doses, methadone may not cause such clinically significant QT interval prolongation leading to ventricular arrhythmias or torsade points. And methadone will take about 5 to 7 days for a sustained blood level, or 5 to 7 days to have uh, good a good pain relief. So before you increase the dose of methadone, please wait for 5 to 7 days. If the patient is elderly or patient is with liver impairment, it will be better to wait for 10 to 14 days. So that's it. Thank you. If you have any doubts, please ask.
Thank you, sir. It was a wonderful session, and you have covered everything, as well as you have shared the stories as well of the three patients. And it was also beneficial for our for those who are attending this session. I think all of you got some idea on methadone, and methadone is a newer drug, so most of you have so many doubts in your mind. So, though the
So I
yes,
can
sir.
see one query in the chat. So the patient is taking 240 milligram. 240 milligram divided by 20, because patient is taking more than 200 milligram. So the conversion ratio is 20:1. So 240 divided by 20, that will come to 12 milligram of methadone per day. So that will be 5 milligram BD or 4 milligram TAD. So total 12 milligram.
Sir, during the discussion of the methadone, there was a question in the chat box by Dr. Priyanka. Why the long-acting opioid is an indication? Can we go for extended release morphine?
Okay. Yeah. That is also an option. Sustained release morphine is also an option. But compared to sustained release morphine, the cost of methadone will be less.
Thank you, sir. Sir, another question. What is the other option for hyperalgesia?
So maybe I'm not sure, but opioid switch is something which is usually done for hyperalgesia, or maybe even ketamine might be an option because it is also another NMDA antagonist.
Thank you, sir. Sir, another question. Is there any cross-allergy component among opioids?
So opioids are divided into 3 chemical groups. I don't remember which all come under which groups. So in each group, uh, uh, suppose 3 medications is coming under one group. So if one of those medication is allergic, the rest 2 cannot be given. But you can give another a medication from the other chemical group. So that's why methadone is coming in another chemical group. That's why methadone is a choice if the patient is allergic to other opioids.
Okay. Hope it's clear for Dr. Priyanka.
Sir, actually, if the patient is having allergy to morphine, can we go for fentanyl in that case, or does it fall in the same group as you're mentioning? Because normally we're using morphine quite often. So
yeah, exactly. I don't remember in which group fentanyl and morphine comes. I can refer and tell you, but I am unable to answer you as of now. But I will come back to you.
all right, thank you.
Sir, another question which is asked by Priyanka itself. What's the incidence of torsade points with methadone?
So even though this is not clearly described, it is what you have to understand is it is more when you use hundreds of milligrams of methadone. So I have given you a study by MD Anderson Cancer Center where they couldn't, they actually gave methadone for 100 patients, and even though there were some dropouts, they could follow up other patients where there were no incidents of torsade points. So it should be very, very less. And also, most importantly, it depends on the dose of methadone you are giving.
Okay, sir.
So any other doubts? Kindly unmute and ask. And today, this is our last session. So if you have any doubt on previous sessions also, you can ask. In case no one is having any queries, I think Sunil sir, with your permission, we can move on to the feedback part.
Yes, yes, please.
So this has been a wonderful journey, I believe, of 20 sessions with many vibrant participants joining in for the sessions, and there has been a lot of interactions as well. So now we would like to hear from you. What went well? What could have been improved? Where you felt that things could have been more better? So it is now open to the participants to share their kind words with us. We would be extremely happy if someone could unmute and say out the feelings. Thank you, Dr. Madhumita. Yes, thank you. So I think somebody unmuted.
Good evening. This is Dr. Suchitra. I really enjoyed the sessions. For me, this was my first exposure to palliative medicine. And what I found is the sessions where, like today, where case discussions were there, and we were able to discuss about cases. It's easier to understand the concepts, at least for a new person who's being exposed to this. So I found those sessions the most helpful, rather than when there's a lot of theory, because it seems to just go above the head. Because when we see it as cases, it's much more easier to understand. So maybe in future, if all the sessions could have a dedicated section with cases like today, where different patients are discussed, that would be very helpful. Thank you.
Thank you, doctor. Thank you, doctor. Thank you so much, Dr. Suchitra, for that very valid point. We will definitely work on that, and maybe we can also have a faculty panel to look into the same.
Shri Priya, I just want to make a comment on the opioid allergy. So the chemical classes which I described are phenandrins, phenylpiperidims, and diphenylheptanes. And in phenandrins, morphine, codeine, buprenorphine. Okay, so those are the three medications which come under phenandrins. And in phenylpiperidims, it is fentanyl, pethidine, and diphenylheptane is methadone. So if a patient is allergic to morphine, then fentanyl should be okay.
Okay, thank you so much, sir. That would be very helpful.
Thank you, sir.
Good evening, everyone. I'm Dr. Priyanka. As you asked for feedback, so I would just like to mention that it was actually a very informative experience for me as such. Though I'm working in palliative care and looking at patients, but to learn from people who are so much more experienced is really wonderful. And the sessions had been really great. And as mentioned by Dr. Suchitra, case discussions actually from real case scenarios help you understand it in a more relatable way. One more thing I would just like to add is that, as I mentioned earlier, also, I think I would be personally very interested in learning psychotherapies or psycho management, like psychological approaches, because I don't want to refer my patients to psychiatry or psychology department as such, because probably I'm not very sure how well they'll be received also. So if there is something like that where we can maybe get an idea from experienced teachers, that would be really great. That's just what I feel. Otherwise, it is a wonderful experience all in all. Thank you.
Priyanka, where do you work?
Sir, I'm working in Dehradun currently.
Which institution?
Sir, it's SGRR Medical College.
Okay, thank you.
Yeah, so.
Thank you, Dr. Priyanka. Yes, of course, we would also bring this point to the notice of the uh, curriculum development panel so that they can work out on it as well. Thank you so much for that valuable point. Anyone else would like to?
I'm Dr. Madhumita Murthy. Yeah, I'm from Chhattisgarh, working in medical college here. Yeah, I would like to thank the entire record team and especially Cypriya. Shripriya, she has been with us throughout the program. I attended all the sessions. I was really enthralled to know, to get such elaborate information from such experienced people. I would like to know that if more of case presentations could have been incorporated in this session. And secondly, suppose since we have just started palliative care here in the medical college, if we have some problems, can we get back to you after this program is over?
Yes, definitely. That's what we would like to have because we don't want to finish our collaboration or partnership with this course alone. We would like to work with you, and any of you need any help regarding palliative care, we are ready to do that. And we have a telehealth center also, in which you can direct the patient, or even if you want, you can call. So you are welcome if you have any doubts or if you need any help.
Thank you, sir. I just wanted that, yeah, like Dr. Priyanka said, if a patient has some problem like generalized neurological problem, he is not able to speak, then what are the communication skills we can have to establish communication with him?
Yeah. So I think these are practical questions, but some of the things which we use are showing them the pictures, and then use written placards. And we had a patient who had a motor neuron disease, and he was unable to use his uh, hands, or he is unable to speak, but he can move his mouth muscles. So what actually we did was we designed a mouse which can be which can actually work by the movement of mouth, so that the patient can write whatever he want. So these all are innovative ideas, but there are something which we can definitely do for these patients.
Yeah, thank you, sir.
So this is Jyoti from Gujarat. You just, am I audible?
Yes, ma'am.
Yeah. So you just mentioned about the mouse you design, which works with the mouth movement of the mouth. Now, is that technology available for everyone? Like, can someone else who needs that?
I have to speak to our source person.
Okay. Okay, sir. Yeah. Thank you.
We actually developed it with help of an engineer,
Right.
software
Because
engineer. So
there's
I
a
will ask.
Sure, sir. There is a similar patient here. with us. Like, so when you said, it clicked in my mind that if we can give that thing.
Okay.
Sure, sir. Yeah, thank you.
Any other valuable comments, observations we can take in?
Dr. Sunil Kumar. Sir, what is your experience with PEG tube? Suppose a patient, one patient we have with motor neuron disease, MND, is not able to take oral food. So is a RAS tube feeding comfortable, or you advise PEG tube inserted?
So Dr. Madhumita, thank you for asking that question. Even though this is a simple question, but I think practically, if you look at it, it's very complicated because we have to actually understand what is the stage of the patient and what is the wish of the patient. Because it all depends on patients. But if the patient is affordable, definitely PEG tube feeding would be more helpful than rails tube feeding. Uh, but even though this is a single word answer, I think there are many factors need to be taken into consideration before we come to conclusion that the PEG feeding is better for this patient. We have to actually look at what stage of the disease this patient is in. Then does he actually want artificial methods of nutrition? What is the family's wish? So all this has to be taken into consideration before we come to a decision that okay, we can actually make this patient undergo PEG feeding.
Okay, sir. Yeah, actually, he's in advanced stage of motor neuron disease, and at present he is taking mashed food with spoon, caregiver, and at present he doesn't want to have a PEG tube inserted, though his family wants that.
I think you should have a discussion with the patient and ask him why he don't want a PEG feeding, and also make him understand what are the benefits as well as risk of PEG feeding. And by understanding this, including everybody knows that if they don't take anything, there will not be energy, and they may after some time may succumb to death. So if the patient knows that okay, without doing this procedure I cannot move forward, then if he has the mental capacity also, then I think we should respect that person's wish.
Okay, thank you for your feedback, sir. Thank you so much.
Thank you.
So we have a
Good evening, madam.
Yes, doctor, please.
Yeah. Good evening, madam. I'm Dr. Nagarjuna. I'm calling from Hyderabad. Actually, I'm an anesthesiologist, madam. I'm a professor of anesthesiology in Gandhi Medical College. This is actually I just wanted to thank all the faculty and the Pallium, and also the online session has taken Shripi and on all those things. And it was a very good, though it is just a 6 weeks program, but it was really a very informative. In our hospital in Hyderabad, we have MNJ Cancer Hospital, which is affiliated, which is attached to Usmania Medical College. We have the other medical college, which is a Gandhi, the second, almost it is a 14th position in the top 20 medical colleges in India. But we don't have the palliative care center. Just recently, two years back, we have started pain center. but with an initiative of the exposure, and we have done some refresher courses, 1 week course, or some very short duration courses in MNJ, but that was not much of useful. So actually, I wanted to visit the 10 days on-site session at Pallium. It couldn't possible because of the hectic work here as a unit head and all I was managing. So anyhow, this 6 weeks, the foundation course really thrown a lot of light and really given a lot of information on which we would like to build upon, and would like to thank you very much for your all your support. And with the other participant, we have also came to know that your support is going to be there for some quite some time, and you are going to have our collaboration. And we are very thankful for your kind words, and thank you very much with all that sessions you have continued. And as far as the sessions are considered, they are all very informative, and they are very extensively covered. And with this feedback, I'm very thankful to you. And I would like to have this 10 days on-site session also, because though we have started the pain the center, but not a proper palliative center. And during the interactive sessions, what I came to know is those who would like to start the palliative care center, if we have the hands-on training for a 10 days, and it's going to be very useful, I came to know. I'm looking forward that 10 days on-site session, madam. And also, if possible, I'm also looking for this 1 year course also. And just if you let us know that, and we are going to join that also, madam. With this thing, I would like to thank once again Sri Priya and all the faculty of the Pallium, and thank you very much.
Thank you, Dr. Nagarjuna, for those warm and kind words. Yes, regarding the 10-day on-site courses, whenever we announce new courses, the WhatsApp group which we created will be maintained and the information will be provided through the group. And you are also free to keep checking our website www.palliumindia.org for the latest updates. And regarding the 1 year global fellowship program, the first batch has already been started, and we do hope that we will see at least some of you in the next year batch.
Thank you.
And the hands-on training, if any of you are interested, please write to us, and we will try to accommodate you according to the number of candidates we have, because we also conduct on-site training. So we will have those participants along with us, but we will definitely try to accommodate you, because
Thank you very much.
you are actually interested to do and
Yes.
learn and practically apply this knowledge. So
Thank
we are,
you very much, sir.
we would
Thank
be
you.
always supportive.
Thank you very much, sir.
So the one link is open on the website for the 10 days hands-on course. So I had filled that up. I was not very
Okay.
sure. The dates were not there, but still. So
Sri
if
Priya,
Yes, sir. We will definitely take that up.
Sure,
One of our
sir.
colleagues, Sister Sheba, is in charge of the on-site training.
Okay.
So since I have already known that Dr. Jyoti Vaishnav has submitted your application, I will definitely get in touch with Sister Sheba and get back to you with the update.
Thank you very much. Thank you.
So I believe if no one else has anything more to share, of course, the chat box is getting filled with warm messages. Thank you everyone for that. So paraphrasing the words that in palliative medicine specifically, there is nothing, no words as such that there is nothing more that can be done, but there is always something which can be done. I think, sir, you want to add any final words before we take it up, me and Dr. Bhishma?
no, I think I see there are about 50 participants in this course, and it was our privilege to have you with us for this 20 sessions. And it is actually a mutual learning. And as participants, you will also come with many things which will be informative for us also. So Thank you for being with us.
Dr. Grishma, would you like to say a few words on behalf of all the facilitators?
Yes. Uh, in chat box, we have received many grateful thoughts. And thank you all. And as sir said, be in touch with us. And if you have any doubt, you can write up in WhatsApp group or email, or you can directly call us as well. So I hope you all have some good idea on palliative care, and we all welcome you to join us in hands-on session as well. So with this,
Dr. Nagarjuna, you are unmuted. Would you like to add something?
Yes, ma'am.
Yes, sir, please.
Madam. Yeah, yes, madam. We are looking forward. This journey, what has started 6 weeks back, is not stopped, madam. I think this journey is going to continue, and we are looking forward your support in the future, our endeavors also, and we would like to come for the 10 days on-site session, and also we are looking for this 1 year session, and also throughout our journey, whatever doubts we have, because they are all eminent faculty are there, we would like to seek their help and support as and when we required, madam. And I really thank the online sessions really done a great job in coordinating and everyone, and we our heartful thanks to Shri Priya and team, and thank you very much, ma'am.
thank you, sir. Thank you.
Thank you, sir. So, yes, one thing I definitely can promise on behalf of the Interpallium India team that we are here. You can get in touch with us through the WhatsApp group, through email, or our telehealth service, or by any means, or through our website. Whenever you need, whenever you require our support, we are there. So, that assurance, of course, we can give you because our organization believes in that the people who need pain relief should get it at their place. So that is our end motto, and we believe that the baton which we are handing over to you, you will definitely use it in the most judicious and successful way in your areas of practice. So that is all. Only the online sessions are coming to an end.
Yeah.
We will definitely keep in touch with you. Maybe small seasons greetings messages at times. Even that will prove that we are in connect. So that will always be there. Along with that, we'll be sharing any major updates which we feel will be of importance to you all. So that also will be there. So with that positive note, this is Sri Priya, along with Dr. Sunil Kumar and Dr. Grishma, signing off for the last time from the Tips Eco Hub. We will stay connected and we will make many lives pain-free in coming days. Take care, everyone. Be successful. Be happy always. Bye-bye.